Welcome from Australia, and my apologies for not being able to be there in person. The NHMRC congratulate MARTS and the organisers on addressing this really important issue. It's important for us, as you'll hear. So what I plan to do is just run through a little bit of what's happening in Australia and then some thoughts on the sorts of research that we might need to do at the end. So on this first slide, just a summary of Australia's health system. As we know, every country has its own variations of their health system. Australia is a mixed system, publicly funded, universal health insurance, but private provision of some service. Access for all means that everybody is entitled and can access all parts of our health system. For people of lower socioeconomic income, subsidised access where that's needed, including the private sector, and there's a range of supporting infrastructure which can be summarised really as each of Australia's 8 states and territories run the hospitals, the Commonwealth runs the national body. So I mention that because policy around limiting and addressing antimicrobial resistance has to obviously be embedded in the policies and structures of each nation's health system, and that's, I'm sure, something you are all aware of, but is one of the challenges I think that we face in this area. So the next slide has a little bit about antimicrobial resistance in Australia, the current situation. We're a high user of antibiotics, although for human beings, all on prescription. But overall, the levels of AMR, of resistance, are lower than in many other countries. Once this was a hospital problem, but now, like I'm sure many other countries, it's also a community problem. So it is not uncommon for patients to arrive at hospital carrying resistant bacteria already. This community resistance varies across Australia's diverse populations, but unfortunately is particularly high in some of our Aboriginal peoples' communities, Aboriginal and Torres Strait Islander communities. As far as surveillance in Australia is concerned, of course, as you all know, this is complicated because it's to do with the interaction between environmental, epidemiological, clinical, behavioural factors in humans and animals, in medicine and in the agricultural system. And therefore the surveillance data needs to come here from outside the normal suspects, the normal parts of the health system that perhaps most of us, and certainly here at NHMRC, are most used to dealing with. The collection of data and its analysis is patchy in Australia. At our big teaching hospitals, our tertiary hospitals, there's information collected, but there's little national coordination of that data, and that's a challenge that we're trying to address, as you'll hear in a moment. And at the moment there's very little, very scant collection of data around community-acquired resistance or in food production, in intensive farming and elsewhere. So one of the things we have identified is that national data are critical to getting our act together here in Australia. So getting our act together, a new strategy was set up around about, I guess, a year or so ago, the Australian National Antimicrobial Resistance Prevention and Containment Strategy. And the first dot point quotes the government when it was setting up the strategy. Here at NHMRC, we do think this is really important, and it's a major step forward in Australia's response to this growing national and international problem. It includes an integrated national surveillance system for antibiotic resistance and antibiotic usage across both human health and agriculture, the so-called One Health approach. It's been given high priority, and that's indicated by the fact that the senior public servant in charge of the health department and in charge of the agriculture department are joint chairs of this new strategy, and it's been allocated some funding from the government to roll out. Now, just turning briefly to the National Health and Medical Research Council, we are a research funding body, but we have broader roles than that. Development of standards, particularly consistent standards between our states and territories, as well as fostering medical research and looking at ethical issues in health. And as the virtuous cycle on your screen shows, this is what we think about, what we do. If the government gives us money to invest in research, we do create knowledge, but given those other roles that we have, we try and make sure that the various ways in which public health can be improved are also accelerated through a number of our actions. As far as funding research in this area is concerned, like most other big government funding bodies, we're primarily an investigator-initiated scheme. Although we have a wide range of schemes, we have centres of research excellence, we have partnership projects with the health system, as well as the standard project grant type approach. We haven't had many applications, nor do we fund extensively in this area, in the specific area of antimicrobial resistance. Back 10 years or so ago, we had very little funding, and although it's grown now to 65 grants, it's only about $10 million, and we have about $800 million of expenditure on research each year. So it has been not a strong area of Australian health and medical research, although perhaps we think more broadly of the science relevant to antimicrobial resistance, we could point to a wider range of activities, and I'll talk a little bit about that at the end. We have identified as a priority for us in the current strategic plan, which we're halfway through, new and emerging health threats. And so we are looking to do some very active activities in this area, and if we could do it as part of an international consortia, that's what we always really like to do. So again, it's great to be able to participate virtually at this meeting. Just three of our grants for interest shows the sort of diversity. The first one, the CRE on that second line, is the Centre of Research Excellence, and you can see this is a very interesting big grant, 2.5 million Australian dollars over 5 years, are really around trying to develop public policy interventions in that area. We have basic science as well, and Anton Peleg is the winner of our Minister's Prize last year for work in this area. He works in a hospital setting. Then a TRIP fellowship is a translating research into practice fellowship, and again there's some details there of Dr. Chav's work again in a hospital setting. We are one of a number of government agencies, of course, in the health area, and I just wanted to mention some of them. And here, trying to cross that valley of death, a diagram that's in our strategic plan based on one, or with the permission of the cartoonist who drew this for Nature back in 2008. So I mentioned a couple of things. The Pharmaceutical Benefits Scheme authorises use of antibiotics and all other pharmaceuticals in Australia, so sets rules around use of antibiotics. The TGA is Australia's equivalent of the FDA, and it's responsible for all antibiotics and other pharmaceuticals. And we have something called the National Prescribing Service, and it is funded by the government to do a number of things, and one of its highest priorities is a campaign to reduce antimicrobial resistance across the Australian health system. I think particularly focused on patients and health consumers to get through in their mind that they don't push their practitioner either to prescribe antibiotics when that is not indicated. As well, proving antibiotics for use in animals is done by the JPIAMR, and it's also begun to consider implications of resistance to human antibiotics in the agricultural system. So just last couple of slides, when we've been thinking here at the NHMRC about the type of research that is needed, and just to put some things on the table here for consideration, there's obvious need and very high need in my view to continue to work on basic biology, on new agents and new approaches generally to attack resistant organisms, and indeed all organisms, so we develop a wider range of armamentarium. Epidemiology is clearly important, and there's some new areas there, such as the microbiome, I think that are worth factoring into our thinking going forward. I know you've been talking about surveillance during the meeting, so I won't say more about that, but in this highly linked world, surveillance, not just on outbreaks, but on the science behind and on community-acquired resistance, I think is really important. More rapid diagnostic tests are important, new antibiotics, new ways of funding antibiotics, private-public partnerships. That's, I guess, one of the big issues that we need to face here with the big pharma funding models. And if we're going to do smart new things here, let's see if we can put our best researchers internationally together to work. And then finally, and something that sometimes is forgotten, good health systems, health services research, an evidence base so that when we do introduce policies into our health system to try and limit the spread of antimicrobial resistance, we do it on the basis of knowledge, and that obviously involves both human behavioural research and indeed health economics research. So thanks for the opportunity, Mats and colleagues. Good luck with the rest of the meeting, and looking forward to hearing what the outcomes are. Thanks again.